Buenas tardes y saludos desde Berlin. Good evening, and I am very happy to present today infection management of infections after fracture. I will now share the screen. So the infection risk after fracture fixation is about 5 to 10%. So quite high risk of implant-associated infections. And especially after open fractures, it may increase up to 70%. So our aim is to prevent chronic osteomyelitis, make soft tissue reconstruction, and bone consolidation. The main bacteria involved in infections are Staphylococci, Streptococci, and Enterococci, but also gram-negative bacilli and fungi. Often we have mixed infections, so that there are usually gram-positive and gram-negative infections, and we call them polymicrobial infection. The treatment concept involves a proper surgery in combination with local and systemic antibiotics, which can lead to high cure rate, more than 90%. However, we need interdisciplinary concept directed against biofilms. Why biofilms are so important in infections after fracture? The reason is that our body is very efficient into eliminating bacteria which are planktonic, which means free living. This is a granulocyte which is going after a bacterium, try to catch it and eat it. And this happens just now. So most bacteria are eliminated by macrophages. However, if we use implants, for example, plates, prostheses, or nails, then we have bacteria in a different form, which are not free living anymore, but they attach to the surface and build such a structure, which is called the biofilm. So we need to adapt the diagnosis and the treatment to this kind of bacteria. Sometimes it's easy to diagnose an infection, but sometimes it's not so clear, and we call them low-grade infections. The preoperative diagnostics, we use clinical symptoms, laboratory investigations, and imaging. And I will mention also some specifics of intraoperative diagnostics for infections. First, we ask what is a suspicion of fracture-related infection, and most common, this is pain, non-union, local symptoms, or prolonged wound discharge. Then we need to do further diagnostics, which includes laboratory tests, including C-reactive protein and X-ray. Mostly this conventional X-ray is enough. But if we have some clinical symptoms, for example, we see the implant, we have a sinus tract, or even a purulent discharge, then these are confirmatory criteria, which means that infection is diagnosed. However, sometimes we have only suggestive criteria, which are radiological signs, or laboratory signs, or persisting drainage or pain. And then we need to do further diagnostic, often with a CT for bone quality and MRI for soft tissue quality. Rarely, scintigraphy is needed. If we have a delayed union or non-union, then the first thought is infection, because this is highly suggestive for a chronic infection. And we proceed with intraoperative diagnostic. Intraoperative, we use different tissue samples, no swabs, but only large tissue samples to send them for microbiology. However, if we remove an implant, then we can sonicate it, which means that we put it in a box, add some fluid, and then put in an ultrasound bath for 1 minute in order to remove the bacteria from the implant at 40 kilohertz, and then we can detect it in this fluid, which is called sonication fluid. Once we have the diagnosis of infection, we plan the surgical and antibiotic treatment, which consists about radical debridement, efficient antibiotics, and combine this with an interdisciplinary concept. Because if we use only antibiotics without surgery or with insufficient debridement, we will have a problem, either resistance or persistence of infection. Only if we combine sufficient debridement with systemic antibiotics and sometimes also local antibiotics or other additional measures, such as coating of the implant or bacteriophage therapy, then we will have success. But the main question is, do we need to remove the implant or we can retain the implant? If fracture is healed, then of course we remove the implant, the plate or the nail, and treat only the osteomyelitis, which is easier than in cases where there is non-healed fracture, and then we can either retain the implant but do the debridement. If it's an early infection, typically less than 6 weeks, or we change it in 1 or 2 stages if it's a late infection with symptoms more than 6 weeks. In infected nail, we always need to change it because there is no possibility for retention and eradication of infection. So in summary, early postoperative infections up to about 6 weeks, some go even for 10 weeks, then this is an early or a delayed infection, and we retain the implant if this is not the nail, but it's a plate, for example, whereas in late infections, we change it in 1 or 2 stages, and this depends on the soft tissue. If we see here the antibiotic treatment now, if the implant is removed, then we treat osteomyelitis, which is 6 weeks of antibiotics, 2 weeks intravenously, the red arrow, and 4 weeks oral antibiotics, which is the green arrow. If we, however, retain the implant or change it, then we treat longer, in total 12 weeks, and this is usually 2 weeks intravenous, and then we switch to oral antibiotics, which has biofilm activity because we have a new implant in place. Which antibiotics are biofilm active? There is a table in the pocket guide, which I will present later, and there is for each bacterium suggestion which antibiotic should be used. The good thing is that we can switch from intravenous to oral as soon as the wound is closed, CRP is getting down, and we know the pathogen, so we can switch to oral antibiotics. Besides systemic antibiotics, we can also work a lot with local antibiotics because we achieve much higher concentration locally with minimal systemic effects. For example, we use antibiotics in bone cement. This is non-resorbable polymethyl methacrylate, and we can use it either as a spacer or we can use it as a fixation cement. And then we add either gentamicin with clindamycin or gentamicin with vancomycin in order to cover all possible bacteria. We have a broad spectrum. If we know a problematic pathogen, Then in the pocket guide, there is a table which shows for each situation which antibiotics can be used in bone cement, in which concentration per 40 gram of PMMA. If we have, however, bone defects, then we need to have in addition also, depending on the size of the defect and the complexity, to think how to reconstruct. And this can be surgically quite challenging, but depending on the defect, we can use bone grafting, or we can use other methods such as induced membrane or bone transport. If, however, we use resorbable material as a bone void filler, then we have some options to deliver antibiotics locally. Either we add them in materials for osteoconduction or osteoinduction, and here I will mention three possibilities. One is the bioactive glass, which is slowly resorbable and is a good osteoconductive. We can use calcium phosphate or sulfate, which can be also added with antibiotics. Or there are some other products which can be used as beads with antibiotics, or there is already commercially available calcium sulfate with hydroxyapatite and antibiotics. This is one product which has vancomycin or gentamicin impregnated, or there is another product which can be used for antibiotics to add them depending on what you need. So in summary, we have a concept to be used in fracture fixation, and this article is a nice review and can be downloaded for free from Effort Open Reviews. And the pocket guides, which I mentioned, can be downloaded for free from the website of the Pro Implant Foundation, www.pro-implant.org. Thank you very much.